Thanks very much. So I'm going to talk about the influence of the neck and why it's sort of important that we look at it in terms of people with persistent symptoms post-concussion. So as a bit of a background, just to remind you that if you've had enough force to cause a concussion, which is about 60 to 180 G-force, then you've had enough force to cause a neck injury, which is only about 4.5 G. So it is important that we consider the neck in somebody who's had a concussion. So why is it important? Well, neck pain is quite common in people with post-concussion, so it ranges anywhere between 20 to 70%. If patients have neck pain, then there's an associated poorer outcome post-concussion. There's also evidence of impairments in the neck in people who've had concussion. And we also know that the neck can cause headache, and it can also cause dizziness and visual disturbances due to the large amount of sort of afferents from the neck that supply information with the visual system and the vestibular system to the brain that helps with head and eye movement control and postural stability. And possibly there's a potential role for prevention, because people, if they can generate good neck strength, it might be able to decrease the shearing forces that then go through to the brain during a concussive event. And Kerry Peek will talk a little bit more about that. So, how often does this occur post MTBI in relation to the other systems? Because we know that people also get autonomic nervous dysfunction, they get vestibular and ocular dysfunction as well. And so previous studies sort of suggest that, vestibular and cervical was about 55%, and they kind of put those two together. And so this is important because when they've done a systematic review, even up into 2022, the neck wasn't always considered or even assessed post-concussion. So it is important that we look at how often is neck involved. And we also know that the treatments differ if it's a neck versus vestibular or versus an autonomic nervous system function. So it is important that if it is the neck, then we can identify it and then we can address it. And as I mentioned, it might be important for prevention as well. So in this study, we looked at a group of patients who'd had a concussion 4 weeks to 6 months prior and were still having symptoms from their concussion. They were adults, and we did quite an extensive physical examination, which included looking at cervical, musculoskeletal and sensory motor. So this was things like neck movement, palpation of the joints in the neck, sensory motor function like proprioception and balance. And then and neck strength, we also looked at a very large suite of vestibular and ocular measures as well. And then we looked at the Buffalo Concussion Treadmill test as a way of looking at their autonomic nervous system function. So what we did then was we had some matched healthy controls that we used their data to determine what was a cut-off for an impairment across all of those different systems. Then we looked at each patient, and from a cervical, musculoskeletal and sensory motor point of view, if they had at least 3 musculoskeletal impairments that were less than healthy controls, or they had at least 2 musculoskeletal and 1 sensory motor, which might have been proprioception, for example, then we felt that they had a cluster of signs that was significant enough that they probably had a cervical musculoskeletal disorder. For the vestibulo-ocular, they had to have at least 2 positive vestibular tests, and they had to fail the Buffalo Concussion Treadmill test to be put into that physiological group. So we had 34 participants who were average age of about 30, median time since injury was about about 2.5 months. Mechanism of injury were a few different things. The majority were sport, and we found impairments in at least one of those systems in 33 out of 34 of those people. So what we found with the cervical impairments was that 94% of those patients had a cluster of impairments in their cervical spine, suggesting that they had a musculoskeletal disorder. And then when we looked, 50% had physiological, so 50% failed the Buffalo Concussion Treadmill Test, and 70% had deficit 2 or more positive vestibular tests. So what we're seeing there then is that often people have a combination, so 35% had impairments across all of those systems, you know, a lot of patients had at least 2, so they had a cervical and vestibular, or a cervical and a physiological. And there were very few that only had one system involved. So the implications for this are that cervical was very common, and it was seen in most of those individuals. So this really stresses the importance that we need to consider the neck and assess it and manage it in patients post-concussion. We also need the skills to be able to recognise and address the cervical spine in treating these patients. And this might have implications for some of the persistent symptoms. So it may be relevant to headache, dizziness, visual disturbances, those sorts of things. The other thing that this study shows us is that multiple systems is common, and at least 82% of them had at least 2 systems involved. So we can't really silo ourselves. We have to be able to address and treat all of these systems, and we need the skills to recognise and treat these, or to at least refer on to the right people when people have more or one system. And then we found that people also were having problems with that autonomic nervous system dysfunction. This was a bit of a greater prevalence than a previous study, but that was probably because these patients were at a longer time point, and so maybe this reflects that duration of their symptoms. So the limitations of this study were that we just looked at the systems and what they had, but we didn't necessarily relate that to the symptoms that they were presenting with, because in order to do that, you need to do a really skilled interview and link that with the findings to work out the role of the neck, because it's quite possible that the neck could be causing their dizziness or their headache, for example, or it could be completely comorbid and just existing, and it's the other things that are causing the symptoms. It could be mixed, so they could have a couple of different types of dizziness or a couple of different types of headache. So it is really important that we use the patient interview as well as the assessment across all of those systems to be able to identify, you know, what's driving their symptoms, which should be addressing first, those sorts of things. So I think one of the things that I also want to mention is just the implications of these ongoing problems in the neck. So in 94% of those patients, even if it wasn't causing their symptoms, they still have deficits in their neck, which could then lead to another concussion in future, with that inability to generate the force required to try and decrease those impact forces in the brain. Or it could also lead to neck pain or a neck injury as well. So I think that that's important. So this was just in that symptomatic post-concussion population. So what we found there was that, you know, they had reduced range of motion, neck flexor endurance, joint signs, and that cluster of findings. But on the left, we also had a group who had recovered post-concussion in a similar study, and we also found that even those patients who said, "I'm fine, thanks, I don't have any problems," they also had reduction in range of motion of their neck, flexor, muscle endurance, and joint signs. So I think that demonstrates that importance of at least looking at the neck and addressing any impairments that we find from a prevention perspective. So I'd just like to leave you with don't forget the neck post-concussion, and I'd just like to acknowledge the Neck and Head Research Unit at UQ, where we're doing lots of research in this area. Thank you.
got a few minutes for questions. Does anyone have any questions? No one's asked me why I can't turn my head. That's great. Thank you very much, Julia. People may come up with questions soon. Oh, is there one? Sorry, didn't see you.
Thanks very much, Julia. The question I wanted to ask was whether the difference in system presentation was different in your 50% athlete cohort versus the other 50%.
Yeah, we didn't specifically look at that, but in looking at the data, it didn't seem to be. So it didn't seem to be that different. It was fairly well across each one, but we didn't sort of do a statistical analysis of it.
Any other questions? Okay, we'll boil up your questions because we may get a moment at the end as well. Thank you very much, Julia. Now, next we're going to hear from Gill Cowen, who's going to talk to us heads up on concussion, about Aboriginal and Torres Strait Islander people's knowledge and understanding of so-called mild traumatic brain injury. So Gill Cowen, from the Western Australian Concussion Network. Welcome, Gill.
Okay, well, thank you for having me. Today, I'd like to talk about our findings from this Heads Up on Concussion study, which looked at Aboriginal and Torres Strait Islander people's knowledge and understanding of mild traumatic brain injury. So, if I can work the thing. Yeah. Before we start, I'd like to acknowledge the traditional owners of the land on which we stand today and pay my respects to elders past, present and emerging, as well as acknowledging any Aboriginal and Torres Strait Islander peoples in the room. It's been really interesting. My talk has evolved in the last 24 hours, having heard some of the other people present, and I was really quite thrilled, I guess, to find out that lots of the information that we've identified from this study and previous studies ties in with some of the information that we got from the plenary session yesterday, and also relates to some of the information I've received this morning from domestic violence lectures. So it's been, I guess, a really great opportunity that I wanted to thank Nick for letting me attend and present. Okay, so I'm going to start with concussion, but not too much, because as you guys know, I'm preaching to the converted, I guess, here. So this study investigates knowledge of concussion amongst Aboriginal and Torres Strait Islander peoples who are residing in WA, and really the aim was to try and improve education, I guess, and service provision in this group. So it was sort of an early look at, well, what do we know and what do we need? It's estimated that there's about 190,000 to 200,000 TBIs within Australia annually, and that 74 to 90% of those are probably TBIs or concussions. And as you're aware, despite sort of common perceptions in the community, it's not all sports related. It's falls, it's road traffic crashes, it's assaults, it's family, domestic and sexual violence. So I think what really shouts out with that is that actually a lot of those things that are experienced in higher volumes in the Aboriginal and Torres Strait Islander community. And we know that there's increased rates of physical injury, increased rates of head injury, increased head injuries presenting to hospital in that cohort. So that's how this started, I guess, from an epidemiology point of view. But how it really evolved, this study, was that I'm a medical doctor, and I was working in state football, and I sort of, every time we did concussion assessments in my Indigenous boys, I felt like maybe we weren't necessarily doing the best service for them, that maybe my assessments weren't culturally competent or culturally safe. So my initial thought was, well, we should make a validated tool for concussion assessment in these guys, or, well, it was guys, so I always say guys because it was guys, the team. But when I went and looked at the literature, what happened was that we weren't there. We were so far behind there that it was like, well, there really isn't that much literature about Aboriginal and Torres Strait Islander peoples and concussion or MTBI full stop. So this sort of evolved from that. And what I'm going to talk about is phase 2 of a 2-part study. The first part of the study, we did qualitative interviews of people with Aboriginal and Torres Strait Islander who were Aboriginal and Torres Strait Islander peoples, but who were involved either in healthcare, so they'd been trained in healthcare or were training in healthcare, or were involved in first response. And just to summarise quickly, so what we saw from these is that people were basically good at identifying that somebody can get a concussion from not just sport. So people knew what the modes of getting a concussion were, but what they didn't know was how then to specify whether somebody had a concussion or another diagnosis. So there wasn't sort of an awareness of red flags versus amber flags, for example, with moderate to severe versus mild TBI. And it was also noted that it was very difficult to get people not to minimise their symptoms. So people would shake off having a concussion, didn't think it was that an important presentation. And even if they were worried, they wouldn't go to healthcare settings because there were many barriers. But I think what was really interesting from that study was that what we identified was that people get in first responder or healthcare settings that are Aboriginal and Torres Strait Islander get their concussion knowledge and experience not from having had training in that region. So they get their information still from seeing concussions on the TV, from word of mouth, from experiencing it firsthand. Which I thought was, already there's a little flag there of, okay, well, we need to do better just educating the health and first responder professions in TBI and MTBI particularly. So this study, as I said, is phase 2. And this study, we went out and basically did the same thing. So qualitative interviews with Aboriginal and Torres Strait Islander peoples who were not from a health or first response background. They were adults and they were living, again, locally in the Perth area. It had ethical approval from WAHEC, and we had lots and lots of support locally from Marmooditch, which is an Aboriginal training organisation locally. And we basically recruited by snowballing effect, but also by purposive sampling, and we used Facebook for recruitment, which was actually pretty effective. And we managed to get about 12,000 clicks. We had about 1,000 people that were clicked and were eligible. And then we had about 176 people that actually, presented via some kind of technological way to say, we might be interested. We then lost 70% of those to follow up. But fortunately, qualitative study, so we still ended up with good numbers, and we basically interviewed until we reached saturation from the themes. Okay, so we ended up with 24 participants. We were really broad about how people could engage, so it could be face-to-face at somewhere that they felt comfortable with, or it could be via phone, or it could be via online. And we had five phone interviews and 1 online. The rest were face-to-face, but some were in groups and some were one-to-one sessions. 1 participant was from Torres Strait Islander background originally. The rest were Aboriginal peoples living in Perth at the time. 66% were females. And the interviews ranged from about 40 minutes to about 90, I think it was 96, the longest interview minutes in. So they were quite lengthy sometimes, but they were really, really lovely interviews to do. We started off with social yarning and then went into some more specific research yarning, but it was all very casual. It was a really enjoyable experience, actually. It was good fun. I went to lots of different places and sort of met lots of really, really varied people. So what was interesting is that, and I think this reflects the fact that we identified in the previous study that people didn't have their knowledge as a health or first responder from having been educated in TBI and concussion within their training. So we found that the themes were very similar, the 6 themes we identified, to what we'd found previously. So essentially, participants have good understanding of how concussion can occur. So people were really good at knowing that it wasn't just sport, again, which I thought was great. But what they were maybe not so sure about was the fact that they could have a transmitted force from the body and still have an indirect force causing a transmission to the head. They definitely thought that it might not be considered a serious injury, so there was this perception that concussion was something that you could shake off. But there was also lack of clarity around TBI in general and how and when to present. So people would call a concussion anything from a knock where you had 30 seconds of maybe lack of coordination all the way through to 3 months of being unconscious in hospital. So there was a lack of clarity around symptoms and signs that suggested concussion versus something that suggested a more serious injury, which I think made it tricky then for people to understand, well, where do I get assessed and why do I get assessed? What's the purpose of going at X point in time? Trying to think what else I want to tell you. Barriers to healthcare. The barriers to healthcare were phenomenal, and as you would expect. So typically related to previous stigma, experiences of racism, intergenerational trauma, but also really practical things that we've heard today, I think, in the context of the intimate partner violence as well. Things like 58% of the people that we interviewed had caring responsibilities, and their priority wasn't to go and get assessed, it was to make sure that they had to look after the people they were responsible for, and that they couldn't take, kids and sit in ED for 6 hours waiting for an assessment. It just wasn't feasible, so they wouldn't go. Sorry. Apart from that, the other thing that was really, really, really great in this was that these people that we interviewed had so much information about how education should be delivered. So I'm going to talk to you a little bit about that, but before I do, I just want to go through some of the participants' voices to just give you an idea of things that we talked about. Okay, so with regards, I guess, to knowledge about how you could sustain a concussion, they'd be out in country footy every now and then. Somebody would get hit hard, whether it was a bump or whether it was the head hitting the ground. So we saw them quite a bit. We were aware of concussion. But then also I grew up with abuse. Head knocks was a daily occurrence, and then we did talk about it. We knew about concussions. Mum and Nan would say, make sure they're not going to be passing out or vomiting. But then we moved on to this perception of not being able to distinguish concussion from other types of injury that might need different assessment or different management. So one person thought that concussion was the diagnosis that their son had had when he didn't wake up for 3 months and was in a coma in ICU. Again, we've only heard of it mostly through the media. We don't take head injury seriously enough. We just brush it off. And Aboriginal people are not taken seriously. I've heard healthcare professionals say, they're probably just drunk. And that was a really common theme. And it was really, I guess, it fed back into that perception that it's a difficult diagnosis to make because the symptoms and signs will mimic other things, and that often there can be more than one diagnosis going on at once. So I remember one lady talked about things. So she said, you can be unbalanced and staggering, and that people assume you're drunk. That you can feel sad and your behaviour be a bit different. People assume you've got a major mental health complaint. The assumption isn't the TBI, the assumption is something else. Which again feeds back to our plenary this morning, doesn't it? Yeah. So what I'd like to really just focus on, I guess, a little bit more is the concussion education opportunities, because I think this was really the gold from the study. So there's so many opportunities that we're just not taking advantage of that I think we need to work on. So concussion information sharing be integrated with existing services. So suggestions were things like Centrelink or Aboriginal Medical Services. But, it's a no-brainer, isn't it? You know, the Department of Health, the Department of Education, the Department of Sport and Rec, you know, as three government departments, should have the same concussion protocols, educations, processes. Start educating the youth. Well, I mean, that feeds into that, doesn't it? We should, as part of our health in education in primary and secondary schools, have TBI as a thing that we're taught about, as we're taught about, you know, what to do if somebody gets a muscle injury, or what to do if somebody is experiencing low mood and has depressive symptoms. Other things that I thought were really great were, so there was a big advocacy for the TV ads, like the quit smoking ads. Apparently, within the Aboriginal and Torres Strait Islander community, they were really well-loved ads. The one lady said, we grew to love them and we knew the people and we liked that type of advertisement. We should be using things like that. And people like the idea of an ambassador for head knocks. So somebody not necessarily with lived experience, but an Aboriginal and Torres Strait Islander who was well-known in the public sphere that could spread the word. And then one person came up with this fantastic idea. So, and we don't have it in WA, but in Queensland, there's something called the deadly health checks. I think that's right, isn't it? And it's an annual thing, and each year it's associated with a free T-shirt that's designed by a local Indigenous person. So, so you know the person, you get this T-shirt every year that's a new art design. Like, it's everybody quite likes them coming round. But the person said to me, but that's all neck down. There should be a neck up checkup that goes with that, that's added in. And it's like, you know, a neck up checkup, love it. You know, you don't need me, go, you're amazing. So it was just brilliant, all the ideas that came out. The other thing was sharing information on channels that are already being utilised by the participants. So they basically said, look, we're all on social media, we all watch sport on the TV. You know, why are the big sporting you know, cohorts not during the adverts? Why are they not promoting concussion education rather than having betting, for example, as the advertisements? You know, there were all these really great ideas that we were like, yep, well, that's exactly what we want, isn't it? But also really novel things like Bluey. So we should have a concussion episode on Bluey. So if anyone knows the Bluey producer, I have already got the episode in my mind and then the follow-up episode. So we can have mum playing hockey to start with, hair getting hit, off it goes. And then on we can go to when the next one gets a concussion, then they know what to do because they were educated. Anyway, you get the picture. So yes, so a big shout out for children's TV, I think, is also a really good idea. I'm trying to think what else they said. They were just brilliant. Yeah, fantastic. And in fact, one of the people that was involved in this is now actually working as the Aboriginal and Community Liaison Officer at Connectivity TBI Australia, and it is wonderfully providing some of all these thoughts all through those channels. So hopefully some of them will come to fruition, which is awesome. Okay, I'm done. So next steps. So further Aboriginal and Torres Strait Islander-led and co-designed concussion research and education. I still am nowhere near a validated concussion assessment tool, which was really where we started, but hopefully eventually we'll get there. And I just want to put a little shout out to Professor Beth Armstrong and her team, who are currently leading the Aboriginal and Torres Strait Islander concussion study, which is part of AusMTBI, a big study across WA, Queensland and New South Wales, where they're looking about what's needed from communities to understand what outcomes we need to be helping to address. So whistle-stop tour, but as I say, it was a great study to be involved with, and some amazing ideas for how we actually get this out there. Okay, I'd just like to thank the participants, obviously, who we were, generously gave up their time and took me to all kinds of places to have our meetings. Research team. We had 3 med students who checked all the transcription, who were amazing. And we had support from the local Aboriginal community medical health service, regional training organisation, and then I've been lucky enough to be mentored by Fred Yasso, who is the director for CAST, Centre for Aboriginal Studies, and Sinead Hogg, who is from Connectivity. And 3 of the researchers in this study were Indigenous, 3 weren't, so the Indigenous guys kept us on track, made sure that we were appropriately interpreting results. Okay, thank you.
Thanks so much, Gill. That was really a blast. For that Bluey episode, I can say I never persuaded my children who played field hockey to stop heading the ball. I said, wrong game. But talking about the right game, we have next Dr. Kerry Peek, who's going to talk about women, head injuries, and football, perhaps soccer for the Australians here.
Hi, so thank you very much for the opportunity to present what is my favourite topic. So I am going to talk about football, and it is, yes, more about soccer than what you might refer to as football. So I do have a few declarations. I am the lead of FIFA's heading expert group. I've also worked with FIFA as an injury spotter in their last tournaments that they've been completing since they introduced injury spotters at the Men's World Cup. So I've just completed the Olympics and the Under-20s Women's World Cup, and I'll do the Under-17s Women's World Cup next month. I also helped to draft UEFA's heading guidelines, which were released in 2020, and co-led the review of those in 2022. So just to give you some background into the organisations that I work with. So what I want to cover today is really to talk about the incidence of potential head injuries in football. And when I talk about potential head injuries, I'm using the FIFA definition, which is an indirect or direct head impact, the player being unable to resume play for at least 5 seconds and or having medical assessment. I then want to talk about the role of nature versus nurture in injury prevention, and a lot of this talk will be about injury prevention. And then I want to talk about the technical differences in heading. And much of what I will cover today will be based on the publications that I've had in the last few years. So when we're looking at the mechanisms of potential head injuries in football, and these are data from the last Men's World Cup and the last Women's World Cup, and what you'll see here is that the numbers are actually very similar. So 149 in the men and 132 in the women, but what you will see is that the women are more likely to receive medical attention than the men. In both tournaments, they had 4 concussion substitutes, they're permanent substitutions. In soccer, there is no head injury assessment, and players can come on and have a temporary substitution. So we're talking about potential head injuries, but the likelihood is that the vast majority of these are not concussion. The most common mechanism of injury is player-to-player contact, particularly during an aerial duel. But players can be injured by the ball, but one thing I do want to emphasise is that in the men's tournament, there were no injuries via headers. We did see them in women, but we were more likely to see them through unintentional ball-to-head impacts, and again, being higher incidence in women. And it's really important that we do delineate between heading and other types of head impacts, and we really delineate between the short-term risk of a head injury and the long-term risks, because this really determines where we come from an injury prevention perspective, and also the strategies that we really work with in terms of looking at mechanism of injuries and where we can intervene, because heading has its own issues, which I'll touch on very, very briefly. So not all ball-to-head impacts are a header. And we need to recognise that, because a lot of the data where they talk about heading being a cause of acute injury has the data actually merged together. But we do see them. And so this is an injury from the Women's World Cup. And that is a header. But what we also need to recognise is that we do play these sports within a gendered environment as well. So when we're talking about the difference in injuries that we see between men and women, one thing that we need to recognise is that in many countries, led by the Football Association in England, which effectively banned women from playing football between 1920 to 1970, and that had, consequences here in Australia as well. So when we're thinking about, the sporting facilities that women are being exposed to, and many of them don't even have the basics of having a changing room, it's because a lot of these facilities were built at a time where they didn't need to cater for women. And so when we're thinking about whether women are more at risk of getting concussion, I think that it's very easy to think that these are sex differences. Maybe there's a role of the neck, maybe, it's hormonal, but I actually think this is non-modifiable things that we don't want to change. We really do need to explore this from a modifiable risk factor and think about the gendered environment in which women play their sport, in the fact that they are more likely to report their concussions, but they are also less likely to receive adequate coaching. And this is something that we published about in BJSM earlier this year. So heading is a football skill, and we need to think about that in this context to start with, because it actually can determine match results. So between 19 and 25% of goals, regardless of whether you're looking at the men's or women's tournaments, are scored by a header. And whether we're looking at girls' football, boys' football, men or women, the range of headers across per player per match is actually also very similar. So I often get told, but women don't head the ball. Well, that's not my experience in all the research that I have done. Heading rarely leads to an acute injury, particularly in men, but we do see it more often in women. But our concerns really about heading is the effect on long-term brain health. And so again, we need to recognise these differences because, concussion itself is a silent injury, but the long-term risks associated from repeated head impacts is even more silent, particularly as we may not see those effects for many decades. So is heading riskier in women? So I would just say that it's complicated, and it's complicated because this is research that we've done here in Australia. This was led by my honours student that found that because of the concerns around heading, the players are actually not commonly being taught how to head the ball. So you're looking at pool data about 57%, but we're seeing a lot lower rates in women compared to men. And heading is a really complex skill, and it's so much more than the ball to head impact. It's about being able to track the trajectory of the ball, it's being able to time the run, the jump, it's being able to redirect the ball into the goal if that's your aim, it's being able to land without doing your ACL. And as we heard from the orthoptics earlier, maybe there's a big component of this. If somebody's already had, a concussion, that maybe they're not able to actually track the ball, and this is actually increasing their risk. And when we are assessing heading technical proficiency, men and women, boys and girls, do head the ball slightly differently. And one thing that I want to emphasise is that there is a massive difference between standing there and putting your head in the way of the ball and letting the ball bounce off and actually executing a really well-performing header. And we need to make sure that we are coaching the latter, but we really are discouraging the former, because this is where we're going to see increased risks. So a study that we had published about 2 weeks ago, where we actually looked at the technical differences of headers between men and women, and we used the World Cup data simply because we had access to really high quality match footage, and so we could access all the different camera angles to actually look at it in close-up, because it was really hard to look at technical proficiency from just a single camera angle. And so we had 8 games, 4 in the women's game, 4 in the men's game, where exactly the same national teams competed to try and take out some of those geographical differences. And what we saw was that men and women had very similar rates of headers. There was no statistical differences between them. Defenders head the ball much more than any other playing position, and they tend to head the ball in attack, they head the ball in defence. So they need to have a lot of skills related to heading. The number of aerial duels was also very similar. So in the men's game, we had almost 5,000 aerial duels. Around 1% led to a potential head injury event. So you're talking about very small numbers, but trying to unpack what's the difference between an aerial duel that leads to a potential head injury and those that doesn't is also really important to understand. But what we really did see between the men and the women was that women tend to close their eyes earlier before a header. So you might have seen in Ronaldo in that example. I mean, he blinked at the time that the ball hit his head. So it's common to close your eyes, but there's a big difference between closing your eyes, at 30 centimetres or 60 centimetres from when the ball is away. And I'll show some photographs of that later. We also found that women tend to head the ball from the top of their head, and whereas men use their forehead, they have much better use of their upper body, and they tend to complete more controlled headers. So whether that's a skill and coaching component as well. So these are just some examples, and as I say, there's a big difference between closing your eyes at the point of ball-to-head contact versus screwing your eyes closed and really not being aware of the players around you. So is there a head coming towards you? Is there a foot coming towards your head? If you're in an aerial duel with your arms by your side, again, you're not protecting your space. And we'll go through some of those examples. And it's not just women, it's also boys as well, and we'll also see it in less skilled men. So if we have a look at some examples, and this is my favourite picture from the Women's World Cup because it really does capture the complexity around trying to compete from an aerial ball, and it's not just those that you're duelling with, it's also the interference from other players. So these videos will play very quickly. So you may miss what I'm trying to look at when we're sort of assessing technical differences. But if you have a look at them in still photographs. So at the moment, you've got two players who are competing for an aerial ball. Both players have their eyes open, both are just tracking the ball at this stage. Now you see the player in white has closed her eyes. She's also leaning her head back. So she doesn't know really what the Spanish girl is doing. So now that is an at-risk behaviour for me. Now you can see that both players had their eyes closed. Their heads are starting to come together. And then as they bounce off each other, then this would be an at-risk situation really for the player in white to actually have back of head-to-head contact. And that's partly related to the skill. If we look at this example, which you probably missed, oh, sorry. So this example is quite different because you see the player, the American player, she actually has her arms up. So even though as the Dutch player comes in, she has her elbow high, again, this could be a mechanism of injury of elbow to head contact, but she's actually the American player is actually protecting her space so much better that even though they now have their eyes closed and the Dutch player closed their eyes much earlier, is that this is then less likely to result in a potential head injury, and all of these elements are coachable, and that's the thing that I really want to emphasise when we're thinking about non-modifiable risk factors related to sex. Let's really focus on the low-hanging fruit and where we can intervene to have an effect. And just the final example here. And this is, again, something that we commonly see. So when I concussion spot for FIFA, one of the things that I always get really quite nervous about is a corner. Very few goals are actually scored by a corner. You're actually more likely to get a head injury from a corner than to score a goal. So you've got lots of people bouncing around. Sometimes their arms are up, sometimes they don't. But that's always the concern, is that you'll have head-to-head clashes, and that will lead to, a player sometimes having the end of their tournament and unable to play on. So something that we have developed is something called header prep, and Julia mentioned the role of the neck, but we have done some work in neuromuscular neck exercises, so something that we want to include in players before they start to head the ball. No player should go out and head the ball unless they've received some training. I thoroughly discourage that. I think if you ever want to assess readiness for heading the ball, is ask a player to catch a ball in front of their face. Players that can catch a ball with their eyes open right in front of their forehead are ready to start heading the ball. If you threw a ball at me, I would do that. I'm not ready to head the ball. I wouldn't want to head the ball. So I don't have the skills developed. So, different players will show readiness at different age groups, and we need to recognise that, and we don't make players head the ball if they don't need to. So this is just going through a study at the moment looking at the feasibility and acceptability. So the key messages really are that the incidence of potential head injury events are actually very similar between men and women. Women are more likely to receive medical attention. Many potential head injuries are caused by player-to-player contact, but we know that women are more likely to be injured by the ball. Spotting the mechanism of potential injuries can be really quite challenging, so that's why we need to have that really good relationship with our players if you work as a medical person with any of the teams. Some potential head injuries are preventable. In fact, I would say the vast majority are preventable through good coaching. And heading is a really complex skill, and we need to recognise that. So when we're thinking about whether we need age limits around heading, I mean, all these conversations I'm happy to have, obviously not in a 15-minute presentation, but we need to recognise if heading is part of the game, it absolutely has to be coached. Otherwise, we're creating a perfect storm to actually increase the risk of injury in our players. And the final thing that I would say is that not every young player will become a professional player. In fact, very small percentages, but every professional player was once a young player. So if we only focus on our professional athletes, then we've missed the primary time to intervene. So we must have a universal approach in our young athletes, and that's really where we have to focus all of our interventions. If anyone has any questions, please feel free to email me. And thank you very much for your time.
Thanks very much, Kerry. I'll try not to think about all the times as a 6-year-old I was heading that large, heavy, wet leather ball. Okay, so our final speaker today is Sally Vu, who is going to talk about the return to physical activity and exercise following a so-called mild traumatic brain injury. Sally.
All right. Hi, everyone. Thank you for all those who've presented today. So today I'll be presenting 3 of my studies as part of my PhD at Flinders University. I do want to recognise those on the screen who has helped me with the PhD journey. I'll be going through 3 of the studies today. They're in different versions of publications now, some published, some not yet, but we'll get there. Green button. There we go, thank you. So recently there has been a shift in paradigm, as you know, from rest is best to undertaking more exercise in the initial stages of a mild traumatic brain injury or a concussion. And this is seen through the new terminology, which they call relative rest, and also seen in terms of they recommend starting exercise earlier within 48 hours. With this, there has been an upsurge in research looking into concussion and exercise. So that's why we undertook a randomised controlled trial between 2010 to 2021 so that we could synthesise the literature. I do recognise that I did an updated search. There were 19 additional studies since 2021. So the whole field is taking off tremendously. So broadly speaking, in the systematic review, there were 11 included studies, 8 which were aerobic and 3 which were vestibular in nature. For aerobic exercise, a meta-analysis of 3 studies showed that aerobic exercise compared to usual care did improve overall persistent symptoms following a concussion or mild TBI. All aerobic exercise programs had similar features, so they either had a sub-maximal or sub-threshold aerobic exercise intensity. Sub-maximal was defined as exercising below an individual's age-predicted maximum heart rate, and sub-threshold as the percentage you achieve on your exercise tests, such as the Buffalo Concussion Treadmill test, as previously mentioned. They recommend that you should either follow about a 60% of an individual's age-predicted maximum heart rate or 80% of the heart rate you achieved on your graded exercise test, such as your Buffalo Concussion Treadmill or bike test. So they also found that interventions lasting more or less about 6 weeks or more had greater effects on persistent symptoms than shorter interventions. So treadmill running and stationary cycling were the most common modalities, and this is seen through doing the exercise test in a treadmill or a stationary bike. And because they could control the heart rate with, changing your incline, your resistance, so that you were able to exercise within your percentage without exceeding and aggravating your symptoms. In terms of vestibular exercise, so the literature was a bit mixed, so only one of the 3 studies actually reported a significant improvement in persistent symptoms, but this is consistent with the 6th consensus statement. because they report that you should undertake vestibular exercise 10 days or more, and this is what our research also found. The reason why it's a bit harder to look at vestibular exercise interventions is that they should be tailored. The gold standard is to tailor it based on the individual impairments experienced through the vestibular symptoms. And however, they can be addressed by using a combination of your habituation, adaptation, gaze stabilisation, balance and mobility exercises. 2 of the 3 studies did include manual therapy of the cervical and thoracic spine. So again, those aspects are linked. Regarding aerobic exercise programs and vestibular exercise, 7 of the studies included multiple components within their intervention. This included education and advice on returning to work and sport or school. Also included tailored home exercises that you should do at home. And it also included more coordination exercises for those who were returning to sport. 3 of the studies utilised a multidisciplinary approach to care involving physicians, physiotherapists, occupational therapists and psychiatrists. So this multimodal and multidisciplinary approach to care is reflective of clinical practice. So despite the interventions and availability and accessibility of healthcare in Australia, people with persistent symptoms do experience ongoing symptoms beyond expected timeframes, and this does play a major issue in returning to their physical activity. We're not sure why these are impacted, the health professionals are involved, and the process of returning to physical activity, so our survey aimed to explore this. So from the survey, 39 people were surveyed and 39 years was the average. More than half were female and 54 sustained a sport-related injury, mostly from team sports such as football and soccer. Individuals following a concussion/mild TBI reported an array of physiological, cervicogenic, vestibular, emotional, cognitive and behavioural symptoms in the past 7 days prior to completing the survey. And they actually reported this on an average of 2 years and 3 months post-injury. And we did have some individuals reporting this up to 15 years post-injury as well. So prior to their concussion/mild TBI, individuals reported undertaking high levels of physical activity on the International Physical Activity Questionnaire. And following their mild TBI, they reported undertaking low levels of physical activity with an average of 7 hours of sitting per day, so this doesn't include sleeping. So this indicates that following a concussion or mild TBI, these symptoms really do impact an individual and they really impact their return to physical activity. So it's really good that we can address this. So majority of participants reported accessing medical and physiotherapy services. We do note that although 50% of people reported anxiety and depressive symptoms, psychological services was the least accessed service. So as at least 50% of people reported anxiety or depression or both of these symptoms, we analysed this further by subgrouping participants that reported these symptoms and those that did not. We used the COMBI model, which is a behavioural change model, and as you can see, on average, participants that reported emotional symptoms of depression, anxiety, or both of these symptoms tended to agree that all these domains affected them more compared to those who did not, that remained more neutral. So what does this say? This highlights that we need to focus on mental health, especially for returning to physical activities, and we do need to have more mental health services in this field. So in order to understand these factors more, we undertook a semi-structured interview to explore the barriers and facilitators to physical activity. We used the COMBI model and the theoretical domains framework, which work together to identify interventions or strategies that can support positive behavioural change. So the mean age of participants was 39 years, more than half were males, and the majority, again, sustained a sport-related injury. So the analysis identified 6 barriers and 6 facilitators, as you can see in this sort of pointed diagram. So it just demonstrates that the interaction of these factors is complex and that we do need to think about these factors when implementing an intervention to our clients. So I'll now provide you some examples of some of the lived experience from the individuals I've interviewed. So I do thank them for taking their time to share their voice so I could share it today. So as you can see, multiple barriers interact to prevent the return to physical activity, and all participants reported the persistent symptoms as a barrier to returning to physical activity. They reported dizziness and poor balance affecting basic tasks such as walking and personal care tasks, to cognitive symptoms such as slowed information processing, difficulty processing and reading, as affecting more complex tasks such as returning to work and sport. Mental health was identified as a psychological capability barrier to engaging in physical activity, with most participants feeling several negative emotions which decrease their motivation to engage in physical activity. Sensory overload and the environment were identified as physical opportunity barriers, as when individuals with concussion or mild TBI could not pace themselves within their environment, they experienced what they termed as sensory overload, where too much light or too much noise aggravated their symptoms, and this in turn impacted their mental health as they couldn't undertake the physical activities that provide them with meaning. For facilitators to physical activity, participants expressed that having the physical capability to embed their structured therapeutic exercise into their daily routines or at home or at the gym as facilitating their return to physical activity. They also stated that therapy should be fun, so they should be able to incorporate it into their daily life with their kids, with their friends, and also just throughout even the day at work, doing their exercises at work. Others expressed that physical opportunity domains, such as the use of assistive devices, so they told me that, actually multiple people told me that to address the light and noise sensitivity, they found that wearing sunglasses and wearing noise-cancelling headphones, and even headphones in general, really helped improve that sensory overload, so they were able to do more through their day, which in turn improved their mental health as they were able to do the activities that provide them with meaning. So in terms of this meant that they engaged more fully within their community, which in turn helped improve their mental health overall. Health professional support was also identified as a facilitator to physical activity, because they found that the education, advice and reassurance, even the recognition of symptoms as being part of their concussion, as facilitating their recovery, so the recognition and providing the education that they can still exercise, but they'll just have to return via a graded pathway. So one of the key quotes that I remember from talking to my lovely participants is, they said mild is not mild, because they feel that it doesn't represent the sort of the changes in their quality of life and in the relationships that they feel. So this is one point that they wanted me to convey today. So mild is not mild. So with the take-home messages in terms of the studies is that individuals with concussion or mild TBI experience symptoms from months to years following their mild TBI. And these symptoms can compound and become chronic in the long term. And it's a bit of like a chicken and the egg. We don't know if the mental health contributes to this, or is it the prolonged persistent symptoms preventing you from doing your activities that contributes to poor mental health. However, we did find that there are interventions available for people. So this includes high-intensity aerobic exercise, such as your sub-threshold or your sub-maximal at sub-maximal 60% or sub-threshold 80%. and you should include this as part of a multi-component intervention involving education, advice, and home exercises tailored to the individual. It should also be delivered by a multidisciplinary team to enhance the recovery of symptoms and physical activity, especially now knowing what we know about mental health. Mental health should be addressed. It's not at the forefront currently, and it should be, so it would be great to incorporate this as part of your future multidisciplinary intervention. So if you have any questions, please feel free to email me, but thank you.